Hit it.
On today's episode of the Left of Boom Show, we've got a great treat. My great friend Lori King is our guest. Lori has a really unique and interesting background. So she's a clinician. She did a lot of work in healthcare. A clinician. She's then been a union leader and a CEO of a union. So she negotiated both on behalf of the union and then as a management side negotiator with her own in-house union. She then has transitioned now to do consulting on the management side. She has really, great experience, and having all of those that unique background really gives her a great perspective on all the challenges that are happening in healthcare right now. We cover a large range of topics: labor. What are the big labor issues that are occurring in healthcare? We talk about staffing ratios, and then we even hit the hot topic of scrubs versus suits, not the TV shows, but the fashion wear. So I hope you'll enjoy this episode as much as I did, and let's listen in to our conversation with Lori King. Lori King, welcome to the Left of Boom Show. It's great to see you.
Great to see you, Phil. Thanks for having me.
Yeah, it's always great to see you. So we'd like to start off with our guest, just maybe give a little quick background. So tell us a little bit about kind of how did you end up in healthcare labor relations consulting.
Yeah, well, I've had an exciting career. I started as a staff nurse and then was also an executive. And I was the CEO of two state nurse associations, Montana Nurses Association, Ohio Nurses Association. And then, now I have my own consulting business where I help employers navigate workplace issues, building healthier, stronger, more engaged teams and more positive work environments. But I think, what kind of got me to doing what I'm doing now is the associations that I ran were hybrid, right? They were both union and non-union. So I gained a lot of leadership muscle for navigating the politics and the emotion of differing, diverse points of view. I had two boards. One board was a labor cabinet. The other board was a professional, overarching association board. Some of the professional board members were employers of nurses that sat on the labor cabinet. And so I also say, I guess in jest, that I got a quick master's degree in navigating, a union designated organization, non-union designated organizations, protecting the rights of the nurses that were represented by the group. Or by the organization. And it was a delicate balance. I say it was probably the most chaotic job I have, but I honestly enjoyed every minute of it because
It sounds very complicated.
it was very complicated. I was an employer as the CEO, had a represented staff of 48. So they were represented by an independent union.
So you had to negotiate with that staff union as the CEO of the union.
Yes. So I have negotiated contracts, I guess you could say, on both sides, labor and the employer side, navigated ULPs, grievances, and strikes on both sides. And I guess I kind of skipped over, but as a new grad, that's how I learned about unionization. It was a condition of my employment to be a part of the union at my small community hospital. I was handed a contract in HR, and I'm a natural leader. I think my core values are leadership, integrity, growth. And so that was my conduit. That was my platform as a new nurse to use that platform to lead and try and make the workplace better.
Yeah, great. So help me. I mean, that's a really unique background. It may be an N of one, but like it's a unique set of experiences that you bring to your clients. How does having that union side experience help you with your current clients that are either, and probably many of them are also represented, and probably many are not represented? How does that experience play in with that work?
Yeah, I think it's the experience is just having an appreciation for the diverse views. And if I think about, like, your question and how it helps with the client work, is that I think there's perspectives on both sides, and I don't think either the employees or the employer have really a good appreciation for the
Mm,
perspectives that come from often. And it's not because it's ill intended. I think we're so focused on the work that we do and the responsibilities that we have in our role that it creates a clash that we don't understand. It turns into blame, maybe, some workforce issues that we're navigating. We don't understand why they exist. I think that's why they exist.
right. Yeah. I think there's, uh, and this is true, I think, across industries, but I do feel like in healthcare, maybe more than many others, there's like the economics of healthcare, the labor issues, just trying to staff and find people. It takes a lot of work to get to the point that you can be a nurse, that you can be a doctor, and so just the pool of talent is limited. The demand for that limited pool of talent is going up as the baby boomers are their healthcare needs are skyrocketing, and it's this perfect storm of conditions that there is no good solutions, and I feel like that causes a lot of this, maybe lack of empathy would be one way to put it, or just desperation and kind of grabbing at straws at things that probably aren't really good solutions, but it's like we got to do something. Tell
Yeah.
me a little bit about sort of how the intersection of those things are kind of playing out in the labor issues that you're helping companies face.
Yeah, I think back to, being so focused on the role that we play in the industry that we're in, and in healthcare. Healthcare is a business. And there are people in that are charged with the responsibility of making sure that it's a healthy business that's, financially solvent so that we can provide services, etc. Then you have the frontline clinicians and the workers that are delivering the care. And what goes out the window when you deliver care is any business consideration. You're dealing
Mm,
with a human being, and whether they're a very important person or they're someone who's homeless and maybe, dealing with drug addiction, or really, down and out, all of that goes out the window. You're dealing
mm,
with a human being. They may or may not have family there that are also looking at you. And the only thing on our mind as clinicians is, what can I do for this person in front of me that needs help, that I need the resources, I need my workload to be manageable. I need to walk away knowing that I did what I could and what they deserved, to deliver care and get them the best outcome. And I think that's and I might have gone a little deep on that, Phil, but I do think that, we're so focused. I once had a CEO that or CFO that I encouraged to go around. It was on the heels of the pandemic, but I thought, I always tell leaders in healthcare, your team, they can't trust who they don't know. They have to be able to put a face to the name. They don't need to know you intimately, but they need to say, oh yeah, they need to feel like we care. So the CFO went rounding, picked ICU first. He was by himself, a little uncomfortable. He's not a clinician. He's a numbers guy. And he walked up to the nurses station and said, just checking in on the team, how are things going? And it was very busy. Someone made the comment, oh my gosh, it's so busy. Every bed is full. And the first thing he said is, oh, that's music to my ears. So because his focus is finance
yeah.
and the financial health of the organization, which is critically important. But
Hmm.
you can just imagine how that went over.
Sure. And I mean, I think the flip side of that is also true, right? Like the clinicians, a lot of times, like you said, they don't think about it as a business. But if you don't pay attention and have some financial literacy about how that business operates, and it's true in any business, but I think it's especially true in healthcare, and especially true today in healthcare. If you don't have a sense for like how that works, you're not going to be able to deliver care if there is no hospital to deliver the care in, right? And there's a lot of places that are losing, care centers because they just can't financially work. So
I
so
would
it, so it's both, but yeah, probably not a good time to be. Yeah, you don't go down to a packed ICU, interrupting everybody like that, that's number one, just interrupting them and then go like, man, I'm sure glad it's so busy down here. That's probably not the best way to intro yourself.
Yeah, no, I think, we prepared the team for him coming for sure, but it was just he's looking through a different
Yeah.
lens. That was a learning lesson for sure. And I think to your point, um, you know, one thing that we really could be doing better in the healthcare industry is closing that gap. I think employers could do a way better job, not only just sharing the challenges and what's going on that they're navigating every day, trying to make
Hmm.
sure that they financially solve it, but also all the good things that they're doing. They're not doing a real good job of adding to their very full plate, communicating through a labor lens. But
Hmm.
when we think about what's going on currently in healthcare, I think that, we're going to see a lot more labor concern and issues, I think, if we don't do a good job of communicating, because things like 70% or more of the care that we provide in hospitals is Medicare and Medicaid. And those are agencies right now that we see administrative changes and
Yep.
funding changes going on. And those are external pressures that if we don't, even if our sophisticated smart workforce is paying attention to that, we need to pull it forward because of the lens they're looking at. The other thing that I saw, AHA, the American Hospital Association, put out a recent report in the last week, and we're looking at, all the talk about the tariffs. It was like, I think if I remember right, it was 80% of devices and healthcare supplies we obtain from outside the US. So these are financial pressures that, as clinicians, when everything goes out the window and you're looking at a human being in the eyes, taking care of them, we need to be. And then we see operational changes that we're like, this doesn't make sense. It's not
Hmm.
helping take better care of these patients. If we start to talk about the things we're up against as employer to our teams, they'll understand better what we're trying to figure out. And they might even come up with some good ideas on how we can cut costs and navigate the economic waters.
Right. Yeah. Like it's way better to sort of collaborate around that than to just come up with a good idea that looks good on a spreadsheet and then go, here's how we're doing it. Right.
Right.
Why not? Why not? I think that's a good place to pivot to sort of what are some of the key labor issues that you're helping, healthcare clients kind of navigate through.
Yeah, I mean, I think in healthcare, always, well, like we just talked about, I mean, I'm really focusing on we've got to do a good job in educating our teams from the business side of healthcare and
Hmm.
bridging that gap. So that's definitely one. I think there's some cultural things in healthcare, from a labor relations standpoint that create issues. Nursing focus a great deal on nursing. It's the largest employee population in hospitals. And it often creates a feeling of feeling devalued or not respected by other employee groups. So sometimes, if we have to make sure that decisions we make for one employee group that we're considering how is that going to impact the perception of the other employee groups. And I do find even where employers have, and their nursing employee groups are feel valued and respected, and they're proud of the employer and they're proud where they work and the care they deliver, then they begin to speak up on behalf of their colleagues and the rest of the team saying, we have it, but you're not taking care of them, or, so I think that that's definitely another area, is just making sure that we're looking at things globally across departments and across employee groups. Communication, I mentioned, is a biggie. And that's in industry, any industry, right? But
Yeah.
communication, you can always do better with that.
Yeah, you mentioned nurses, and that's kind of like the prototypical, organized group, or a lot of, organizing happens around nursing. But there's a lot of organizing in some other, unique populations. Maybe talk to our listeners a little bit about some of these other groups that are organizing.
Yeah, well, entry level positions in healthcare are there's a lot of competition. There's
Mm.
a lot more competition. It used to be that, if you could get your foot in the door at the hospital, you really had it made because you had great benefits and great pay, and it was there was growth opportunities. And I think, now healthcare competes with other industries when it comes to base pay, and the expectations of the workforce is different. I think,
Mhm.
the new workforce is more focused on, what's in their paycheck, and they'd almost rather have an extra week off
Yeah.
than higher pay sometimes even. So we have to kind of adjust to that. I think the other thing that I find with positions, some of the entry level positions in healthcare, and I'm talking EVS, food and nutrition, some of those support positions like patient care techs, mental health workers, they're not making enough to turn the wheel. A lot of them have a couple jobs, and especially in certain areas of the country, like I do a lot of work in New York. Simple things like how we manage their schedule. If we don't give them more than 2 days off in a row, or if they're jumping from day shift to evening shift to night shift, and then it's hard for them to make the wheel turn because, like I said, a lot of them have second jobs.
Yeah.
And so they're trying to fit two schedules together. I see that all the time. Economic pressures are real. And I see that across industries.
I mean, so I think that's totally right. So you've got kind of like the entry level pressure where across the labor market, a lot of these entry level jobs, wages have gone up and there's a lot of competition around benefits, and some of these jobs you can even do from home. And so like there's, if you were trying to get your foot in the door in healthcare, you might be willing to kind of compromise a little bit in those areas. But if you can go down the road and have a less stressful, make a little bit more money, have a better schedule, you're going to choose to do that, right? So I think you have that issue, but there's also issues at the top part of the house, right? So like doctors, and you've got a lot of more sort of organizing and pressure there. Maybe tell us a little bit about that.
Yeah, we've definitely seen a lot more physicians and the provider group. We're
Mhm.
talking physicians, PAs, nurse practitioners,
Residents, right?
residents. Yeah, I think, there was a shift when hospitals began to employ them out of private practice. They are now employees. And if they don't feel like they can be influential in their work environment, or they're being told what to do without being drawn in to provide their insight and their input on how things should go, then we see them go outside of the organization to
Yeah.
try and get that voice a different way. So it's interesting, this perspective, having been on both sides and being a provider myself. I'm a cardiac nurse practitioner. I'm very proud of that. I see patients 200 hours a year to maintain my license and prescriptive authority in case I ever go back. But, I've had an appreciation for what's going on from both sides. There's decisions are happening quick. We're navigating a lot of challenges in healthcare, but in healthcare, we've got to draw in those that are providing care, physicians, and bring them along with these decisions. Otherwise, it creates that divisive culture. Um, yeah,
I've got a friend who's a physician in a healthcare system that, well, one of his friends who was also there, they're trying to adopt a lot of technology, right? And so they are not so much AI, but I'm sure AI, the issue that I'm thinking about was just more telehealth, but being able to see a patient without physically being there with them. The physician didn't feel comfortable doing that. And the healthcare system believed that it was safe and was within protocol. But when you're dealing with a licensed professional, and that's both at the physician level and even the clinician level, if you're being asked to do something that you feel just isn't safe, or isn't, you feel like you may be putting your own license at risk by doing it, those create like major problems. And these are kind of like, keep you up at night problems, and you want to have power to do something about it. And if there's not a lot of collaboration and discussion, and it's just being imposed, then like you just said, you go, well, I'm going to go seek power elsewhere.
Yeah. Well, and there is a way to deliver safe care in a way that meets the business needs of broadening the services in ways where maybe we do telehealth or different ways of service delivery, but we have to pull the conversation together of those providing that service too, to
Right.
find out, to get their take on how we roll that out. One of the things that I would go back to in terms of, and this I think is kind of on the same lines, that's a huge pain point for both the workforce and healthcare hospitals, is emergency departments right now. And so we're looking at how do we see patients in a different way. And I think the providers, are questioning how we're doing things. They know they're also questioning that, we're boarding patients. We don't have the capacity for the volume,
Hmm.
uh, and my projection is that's going to get worse. We're gonna, with the
Well, it's kind of
a
the
lot
only place. It's the only
more.
place you can go.
Yeah,
Yeah, it's like the only place you can go where like someone is at some point going to have to see you.
yeah.
And if you don't have any options outside of that, then we're kind of, I'm with you. Like we're creating our own bigger problem. Just like the more that we try to make things more efficient.
Absolutely. And, it puts more financial pressure on the hospital when there's more uncompensated care to deliver, and it puts more pressure on the workforce because the workload increases because we have more volume. And so we do start to look for creative models of care, or, ways to deliver care. But it's again, I keep saying this, but it comes back to bridging that gap of what are we thinking from a business standpoint, and
Hmm.
how we carry out the services, and how do we pull that together with those that are providing it, so that we're making those decisions together.
Right.
A richer experience anyway. And
Well, and you
actually,
just give better care, right? I
yeah.
mean, well, so yeah, there's like all of this, these issues, and one of the things it tends to boil down to is staffing. So maybe talk a little bit about, we've worked on these together where this is just um, it's like it's the big issue, and everyone is like, we want ratios, or we want certain guaranteed staffing for us to feel safe that we can deliver care. Talk a little bit about that, and then how that, again, going back to kind of financial literacy and doing a good job of communicating around sort of why we do things. Just maybe talk a little bit about that staffing conundrum, because it's a big problem.
It really is. And it's the main problem and has been forever. You go back in history, and it's hospitals have been trying to solve workforce issues and staffing, the best way to staff. I'm pretty vocal. I was very vocal when I was lobbying for the nurse associations, at the state and national level. And I'm vocal now to whoever will sit and listen to me about legislating healthcare staffing. It's just not a good idea to be having lawmakers making decisions on, how to staff our healthcare system, because we have a law that passes, and then they're the ones making the rules, and the rules don't make sense. And we see it, I've looked at this across all the states, and there's some that have ratios, they have some that require public reporting, some that have, require staffing committees, and the rules around them. One of the rules that doesn't make sense, just to give an example, because I think this is kind of hits at home, is there was a rule in New York that said that, hospitals had to provide um, hours per patient day in ambulatory care settings, and that's like apples and oranges. There's
Hmm.
not hours per patient day,
Right.
in ambulatory care setting, but lawmakers wouldn't know that. They just picked up on the fact that that's a data point that makes sense in healthcare, but it's just not across the board. When it comes to ratios, if I might be so bold, the reason that we can't just staff on numbers of nurses and numbers of patients. And I think that that's proven in that, and there's pushback on this, and saying that there's, studies and research that say that ratios work. And yes, the workload of the healthcare team is directly related to patient outcomes. If we have a less of a workload, then we can provide better care. I mean, it makes sense.
Right.
But we have legislated numbers, like California, for instance. They've had ratios, outlined in the law by department since '99. In 2000, I think it was, I want to say 18 or 19, they added some additional pretty hefty penalties on when employers go outside of those ratios at any time for any period of time. I think it's a thousands of dollar penalty per instance. So if you have one floor, 3 nurses go out of ratio, that's 3 instances. I think it's 20,000 instance. So it's like
Mm.
that'd be 60,000. So you're having a bad day trying to staff a unit, you're at risk. But here's the thing, a very strong law, very strong penalties. They were already holding patients in the ED a long time ago because they couldn't put patients out on floors when they didn't have the right ratios because the law kind of
Yeah.
created this unintended consequence. But if you go back in the last 3 years, which is well beyond this law being put in place and the penalties, Sutter, Kaiser, Stanford, those nurses have all gone out on strike over workload. Didn't fix it.
Mm.
And I think if there was a magic wand for ratios, if ratios actually worked, and if that message, that unions give that we'll get ratios for you, or if somebody's lobbying for that hard in state legislature, if it worked, hospitals I think would be doing it. Hospitals, that's
Right.
an equal priority for the hospitals. I see nurse leadership teams would love not to be spending all their time trying to navigate staffing issues. That's what they spend the predominant amount of time on is, staffing the units, navigating call-offs, navigating high census, low census, changes in patient acuities, breakdowns of equipment, changes in skill level, managing the team. It's a lot. And there's not a simple answer to this complex problem.
And you said it. It's work. The number of nurses to number of patients is like a dumb way. It is a super. You didn't. Okay, that was my word, not yours. But
No, that's okay, but
like
I'm there.
like it is a ham-fisted proxy for what you're really trying to deal with, which is what sort of a patient acuity situation are we dealing with? What is the skill set of the talent pool that I have that's available to deliver care to this group? And it will oftentimes make way more sense to pull somebody from a unit where there's low acuity and we've got, less experienced folks can handle the stuff that's going on down there, but we have to like staff with somebody who has more experience than necessary and they're kind of having a smooth day because they're sort of overstaffed for what they have to deal with while you have a crisis going on upstairs where you
Yeah.
could desperately use that experienced person. Like that's how you really do staffing. And to
Yeah.
force you into a situation where you have to staff improperly and poorly is totally counterproductive.
Yeah, and I see that. Whether it's a clause in a contract or something that, the state law is driving, we're shuffling staff to meet the requirements of a contract and the law, not always what's best for the patients and the need of the environment. A couple things I wanted to bring up too on this is, I think the American Nurses Association, some of the national labor unions out there that are pushing the legislative and lobbying actions are trying to meet the request and the command of what their members want. I've been there. The push and the momentum of what your members expect that are paying dues and belong to your organization, you have to go that direction, the direction that momentum's pushing you, even if it's not maybe the best. And I think the best leaders in those organizations are the ones that are able to articulate and move their organizations and their boards and the leaders in their organizations to do something different. But I think it's just too much of a force. And so to me, that's why I love doing what I'm doing. I'm not in that world anymore. And the political pressures and the guidelines of that you don't talk about, but the things that the bounds of the discussion that you have when you're in those roles, they're not, I don't think, driving good policy. But I tell you, in this space, I love what the state of Virginia is doing. So the Virginia Hospital and Healthcare Association and the Virginia Nurses Association, there isn't a state staffing law there, but there was some momentum in moving that direction. They decided to come together and work jointly together to address the issues outside of the legislative process. And they're doing great work together. It's not easy. And they have the pressure of, the financial pressures of the hospital. VNA has the pressures of members, the hospital association members, but they've agreed to roll out staffing committees in all their hospitals across the state. And those staffing committees they're not prescribed by law. So every hospital can pull those together on their own. They're made
Yeah.
up of 50% frontline staff, 50% management. They're working together to create staffing plans that make sense for their size of hospital, their patient population. So I'm rooting for them to, be successful in that. That's what I think is best. I think those decisions need to be made in the walls of the hospital where you have critical, smart thinkers that know what they're doing and they're living the needs day to day.
And it's different, like different communities and even different parts of different communities have sort of different needs. And so the idea of doing something at a statewide level, for a state like Virginia, for example, or really like most states, right? The needs for a healthcare center in a highly populated city that has, a lot of different types of acuity and different types of issues and
Yeah.
than someplace out in the country. And so you kind of have, it makes way more sense to do what Virginia's doing, which is like we will work together kind of facility by facility, and we'll have a kind of a framework for how we're going to do it. But the results at each facility probably will be way more unique to that facility. That makes way more sense than trying to do
Yeah.
something legislatively.
Yeah. I think it absolutely does. I've looked at all these things inside out and backwards. Obviously, I have a very, very high level of personal interest in patients having good outcomes, in our workforce being healthy. I mean, that's another kind of why behind what I do. Is when I was in my doctoral program, we talked a lot about the research that says that if the healthcare team is healthy and thriving, then patient outcomes are better. So I'm like, well,
Yeah.
that's my sweet spot. That's where I'm going to be. But when I look at these initiatives in different states, the laws, some of the contract language that I see, and I see a lot of contracts trying to, where unions are trying to address the issues too at the bargaining table, that it's not effective when it's a penalty fine type
Yeah.
situation. We're checking boxes, we're turning in staffing plans. The state's not doing anything with those. The community can look at them, but they don't understand them. And I would even venture to say that a lot of the healthcare professionals look at the staffing plans and don't fully understand. Some are a page, some are 150 pages. It's complex. Yeah. There's been a lot of articles out on there's a clause that's in a couple contracts in New York where the employer agreed that if they fall behind in they fall below the planned staffing for a unit, they actually have to write the nurses a check for every instance. And it's really
Creates an incentive to call off like it. Yeah. That's a
it's very,
terrible
so there's
incentive.
never been more call-offs. I mean, the call-offs skyrocketed.
But yeah.
The
Who could have
employer,
predicted that?
well, exactly. And the employer, it's almost less expensive for them to just pay the fine than solve the problem by hiring more people or navigate. I mean, there's all kinds of things wrong with it, besides the fact that when you have a good, well-intended employer, then you're trying to set a culture of there's going to be issues. There's elasticity in the work environment. Sometimes it's less of a workload and sometimes it's more. And we kind of plan for that. But when you have employers that, are penalized or fined, that says that they did something wrong. And sometimes we're going to fall behind and not hit the mark when it comes to staffing because things happen fast and we haven't been able to pivot fast enough, etc.
Right.
And so it sets a culture of, well, you did something wrong, so now you had to pay us. And then it sets that culture of, the workforce, to your point. Like if we call off, we would get more money. We're working hard anyway, puts pressure. It's just a lot. It doesn't make sense. It's not helpful.
Well, Let's switch gears to something that's a little bit more optimistic. So we're kind of coming towards the end of our time. Going back to like where we started, where you have this unique kind of a foot in both sides. You co-sponsor a conference each summer, and there's another one coming up in August. So tell us a little bit about the Big Sky Labor and Employment Conference.
Yeah. So I just love this conference. It's a passion of mine. I met my husband in this work, and we came from differing points of view. In fact, if people looked at us at the time, they'd say, "Man, why? How do those two even get along?" And we created this event because we found that as we talked about labor and employment issues, we found we have the same goal. We just had maybe some different ideas on how you get there. I also felt strongly that I was most effective in my job lobbying for healthcare issues and trying to address the concerns of the members of the association when I went towards bold conversations with people that would likely push back on our initiatives.
Mm-hmm.
Um, and so, anyway, we decided to pull together the Big Sky Labor and Employment Conference, where we bring together the most unlikely discussions and conversations. So, we bring labor leaders together with employers, policy and decision makers out of DC, put them on panels, no
And
slide.
even knuckleheads like me.
I'm so looking forward to our panel this year. It's going to be fantastic. But yeah, to have discussions about, we know what our differences are, but where can we find some common ground and move forward? And I think our vision for that, people love to come together. I think I kind of had to talk Roger into that, to be honest, because he was like, you're not going to get those people in the same room, and they're going to be their discussions are going to be hindered by the role that they're in, and we don't find that. And we pull them together, and they're excited about exploring the conversation and talking at a deeper level about why they come from their vantage point. The ultimate goal, Phil, would be that we're bringing people together that will take that conversation outside of the conference and leverage the connection that they make to say, let's have a deeper conversation about how we can move the needle. I'm, along with probably so many people, am so frustrated at the pendulum swing with
Yeah.
the administrations. And what we're seeing now is obviously, just like, buckle up. But
Mm-hmm.
this pendulum swing doesn't help employers. It doesn't help employees. These changes in rules, it just goes back and forth, and it's the same old frustration. It's costly, and it doesn't help our work environment and our employees in the nation. Like, we really need to be doing things different. I hope these conversations will go outside of Big Sky. That was the vision. I think this is our 5th year. And it just keeps getting better and better.
It's a super unique conference. For anyone that's listening that hasn't ever been, I would encourage you to look it up. It's a room unlike any other. You'll have top labor leaders, you'll have top management side folks, you have policymakers. I'm excited. I'm really looking forward to being able to talk with smart folks on what we call the other side. But I mean, at the end of the day, we're all about improving the lives of working people. Like that's what
Yeah.
gets me out of bed. I know that's what gets the union side out of bed. So the way that we're doing it right now sucks, and I want to have conversations about Washington starts spitting out labor reform that is not about what's good for working people, and whether it is on the employer side or on the union side, it's a bunch of stuff that's like, here's what's on the unions or what's on their wish list. And the employer's wish list is just like flipping back all the stuff that was on the union's wish list last time. But if we actually think about how could we reimagine the way that we do this, you can have some really productive conversations. I'm looking forward to being able to do that. I've missed the last couple, and every time I miss, everyone's like, oh my gosh, it was even better than last year. Anyway, I'm looking forward to be back.
Yeah, it's so rewarding to pull the most unlikely people together and watch them be thirsty for more conversation. There's an excitement of bringing opposing views together.
Yeah.
When you come together, knowing you're going to have opposing views, respecting and wanting to those point of views and wanting to make some kind of forward movement. It's really special.
Yeah.
It's
All right, we'll do a quick round of just sort of questions for fun. So let's start with fashion. Scrubs. When I first saw this question, I was like, is this about TV shows or I'm going with fashion. So scrubs or
okay.
suits?
My gosh, I like them both. It's a good problem to have. So, I mean, if I had my choice, I'd be wearing both 50% of the time. But ultimately, I find myself more in a suit.
Okay.
Uh, anyway, but
I thought
fashion,
you'd
yeah,
pick
like
that, but
scrubs.
all right. Well, okay. How about favorite leadership book, and then just like any, and it could be leadership or not, but just like any book recently that you've that you want to shout out.
Okay, well, this is from all genuine intent yearbooks, Phil, because they're short, they're easy to read, they give good points, and I say that with all genuine, every genuine cell in my body, which is
Well,
why
thank you.
I love our work together too. And I think that one of the things that I learned, and I wish I would have learned long before, we have all of our stuff about ourselves. We could look back and cringe a little. I'm begrudgingly grateful for all the lessons, but what I learned through one of your books is, that hero assumption and that assuming good intent.
Mhm.
I could have done such better, so much better job at assuming good intent in people and not always feeling like I was under the attack. Although, in unionized environments and when you're a union official and you're running those organizations, it's easy to kind of always feel like you're under attack. I got into the habit of feeling that way, and you yanked me right out of that. So I'm grateful for that.
Well, thank you. I appreciate that. It's I have the same problem. So I mean, like the last book, I need to coach myself sometimes to make the hero assumption. So it's not, it's true. You're never finished, growing
Yeah.
as a leader. That's for sure.
Yeah.
So one of my favorite lessons on leadership you taught me, you tell a story about sort of like where you should sit. So just tell us real quickly about that was an early experience that really made a big difference in your career.
I love it. It's called Take a Seat. And, there's science that says that if you sit with somebody, there rather than stand, then their perception is that you are more prepared to listen to them. You spend more time and they will share more. It's a richer conversation. And so when I became a nurse practitioner is when I was exposed to this research, and I thought, well, I'm going to sit down in my patient rooms. So even if there's not, if it's full of family or whatever, I would lean against the wall or give some sort of indication to the patient that that I was there and present. And there were I think there were some times when I picked up on some critical patient conditions that they wouldn't have otherwise shared with me because they had shared with several people before and they weren't heard. And so they thought, well, I'm not going to say that again because they obviously don't care about that. But I love that take a seat. It provides safety. It makes richer experiences for interacting, and I've translated that into leadership. So I think when we're working with our teams as we lead, that we take a seat with them. If you're
Yeah.
rounding in the healthcare environment, sit down in the nurse's station. Don't just do a drive by because they won't share. But if you
Right.
sit down and you ask them, you're giving them an indication you think that you have time. And it
Yeah.
also gives you an opportunity when you go to stand up to give them an indication that you need to wrap it up. It's
Hmm.
hard to wrap it up if you don't have a physical way to send that message. So it doesn't take more time, I'm convinced.
Probably in some cases takes less time, right? Like,
I think, yeah,
because you give that signal and they're like, oh, okay, conversation's over, and you can just you can move on. I love that. I use it. I even use it here. Like I like to go in and plop down in the office, and you have a different conversation than if you were standing up and talking to someone in the doorway. And it depends on the situation, but yeah, I that makes a big difference. Just get on the same level, and it's just a signal. It's going to be a different conversation, and you will share more and you'll connect more.
yeah. And then the last one I'll say again, that you taught me, but like this is why I just love, you work with each other and you share your experiences. But that one last question, you sit down, you have that conversation, no matter how brief or how lengthy, but at the end, just, is there anything else, as long as we have this time? Because you're unearthing something
Yeah.
before it becomes a greater issue. And again, you're indicating that, I care what you just shared with me, and I care to know if there's anything more on your mind. And I can always
Yeah.
wrap back if there's not time to address it. But there are some very simple things in leadership that we can do to connect and engage with our team and diffuse some of those issues that fester, just by adding these tools in. Anyway, it's
Yeah.
all good stuff. I
That's
love it.
I learned that question from The Coaching Habit. So Michael Stainer, that book, but he calls that the awe question, which is, and what else? But that's, yeah. Is there anything else? And that's a great and there's a lot of times you'll have a full conversation with someone and you think it's done. And as the
Yeah.
leader, if you don't create that space for them to go, well, there was this one other thing, which is actually the thing they wanted to talk to you about the whole time, but they just didn't really feel like it was ready. And then by giving that, just kind of like, I want to hear more, what else? Like, okay, well, I'm gonna say it. And you have to create that space for your teammates.
Yeah.
Lori, great conversation as always. I don't get to see as much as I used to, and I missed that, but I will see you in Big Sky. and
Great.
and I really appreciate you taking the time to talk to us today. So
Yeah,
thanks.
thanks for having me.
All
We'll
right,
see
see
you
ya.
there. Okay. Bye bye.